Thank you. Uh, a round of applause again to the two formidable debaters. So we have no conclusion. One had extra time, one had lesser time. Sorry, Dr. Mafitz. Okay, to move on to the next symposium, pain blocks for the regional anaesthetist. Our chairperson, Dr. Ahmad Afifi, who's an anaesthetist and pain specialist in Hospital Sultana Bahia, also a member of the Special Interest Group of Regional Anesthesia, SIGRA. Warm applause, please. Thank you.
Thank you so much, Andy. While our first presenter is preparing his talk, let me first introduce him. He's a good friend of mine, Dr. Khoo Eng Lea. I've known Eng Lea for a couple of years now. We've been working together in pain management. He hails from Ipoh and he's been working in Selayang Hospital for pain management and completed his training in Peter Mac, Melbourne for 1 year. And he's now the man handling pain management and palliative care in Institute Cancer Negara, the National Cancer Institute in Putrajaya. So his talk would be on blocks, chronic pain and regional anesthesia. What can we do? What can we help? Please, Ku.
Okay, hi, good afternoon or good evening. I'm so sorry to talk about chronic pain. I know most of you won't like to hear about chronic pain. When you hear about chronic pain, like, ayo, chronic pain again. So, but I'll promise you this talk is not about the technicality of blocks or, all this number heavy stuff. It's just more about, what can we do, how can we think out the box to help patients with difficult pain control. All right, so this is National Cancer Institute. It's predominantly an oncological hospital. We do have patients undergoing radiotherapy, chemotherapy, but recently we have the gynae oncology service coming in, the breast and endocrine surgeons coming from our sister hospital, which is the Hospital Pujaya. All right, so what am I going to talk about today? So this is just my outline of my talk, to be quick. All right, I'll try to be fast. So first, I'll just in a brief introduction of what chronic pain is all about. Secondly, I'll just talk about how regional anesthesia and analgesia help in intractable cancer pain, managing acute pain in chronic pain patients, managing pain for wound dressing, and preventing how can regional anesthesia or analgesia prevents chronic pain. So I'll spend more time on the first two topics because I think I have patients that I can talk about. So according to the ISP, this is the definition of pain. But as we look at the definition here, there's always a caveat to it. If you look at it, there's always actual or potential tissue damage. All right. So this is more for acute pain. But when you talk about chronic pain, there may not be any damage ongoing. All right. You may not understand what I'm telling. Later, I'll just go on. Okay. So when we classify, how do we classify pain? So not all pains are the same. So we should ask how long. So 3 months, more than 3 months chronic pain, less than 3 months subacute pain. Maybe first 2 weeks is still under the acute phase. And what's the cause and what's the pain mechanism? So like I said, acute versus chronic. Acute is pain of recent onset. Chronic is pain persisting beyond healing of injury. Sometimes we don't believe the patient is having pain, although they say they're having pain, because when you look at their x-rays, we look at the scans, everything is fine, everything has healed. So if you look at the spectrum of pain here, so acute pain, when you have acute pain, when you have an injury, when you go for surgery, where there's a tissue damage, healing takes place, the pain goes away. But when you talk about chronic pain, the onset can be insidious. We don't know actually what happened and when it happens. So acute pain can be post-surgical, can be post-trauma, or it can be cancer. So but when you talk about pain here, do not forget that pain is just a physical manifestation. In chronic pain, there's always a total pain concept here, which is coined by the palliative care unit. There's also psychological, social, and spiritual component to it. Never forget this, because this is how, sometimes when they present to you, they will present differently. So chronic pain as a whole is 30% of the population in the Western population. So management has to be multidisciplinary. So a pain specialist can just do an assessment, medication, behavioral therapy, or any sort of injection intervention. But also we have to take into account we need the physiotherapists and the occupational therapists to come in, to improve their exercise, and we improve their function. So in chronic pain management, or even in acute pain management, when we provide pain relief, it has to translate to functional improvement. I mean, if no point if you give them a good pain relief, but they are lying down on the bed and doing nothing. So if we can provide pain relief and they can show that they can improve their function, even for acute pain, I think that's the thing that we should aim for. Okay, next I'm just going to talk about how can regional analgesia help in intractable cancer pain. Okay, I'll illustrate it with a case that we recently have. It's Mr. CCW, he's a 60-year-old gentleman. She has CA prostate with bone mets. Bone scan shows the cancer has mets everywhere, but we should look at his symptoms, so where he complains of pain most. So mainly he has a right hip and upper femur, not femur, sorry. Right hip and upper femur, and left on the chest wall because of the multiple mets at the left side of the chest, the ribs. So he was started on morphine, the usual thing, gabapentin. Even on high dose, the pain is not well controlled. So of course, he's been already managed by a multidisciplinary team. So what next? What can we do next for him? So this is sort of patient that nearing the end of life really. When they call upon us to deliver, we try our best to deliver, and we must deliver to help them to have a quality life. So cancer pain prevalence is more than 50%, and a fraction of them may not respond well to standard treatment, and additional options are needed. All right. So this is the modified WHO energetic leader. I know there's 1, 2, 3 that you learn. So number 3, where you have severe pain, you use strong opioid. But what happens if strong opioid doesn't work? What options do we have? That's where we can think of any sort of intervention to block the nerves. And this is at the step 4, where we can do intervention for cancer pain. So you consider intervention when unacceptable side effects despite successful analgesia with systemic opioids. Means the patient is getting a lot of sedation, the patient is sleeping the whole day, despite his pain is under control. Think of intervention. Or the medication is just not effective at all. So what are the evidence for intervention in cancer pain? So if you look at the ciliary plexus ciliary plexus block is well described in cancer of pancreas, and intrathecal or spinal analgesia is one that we always use. All right, and this one interesting about these two intervention is it actually improves survival. So does it mean that this intervention actually has it's like a chemotherapy that sort of like retard the cancer growth? No. Yes. No. Actually, no. Because if you look at it another way, if we provide good pain relief without the side effect of opioids. I mean, when we're not zonking them out with morphine of 100 milligram BD, they can breathe better, less respiratory depression, they can function better, of course, they can live longer. Or of course, she was in Selayang Hospital, spinal catheter was inserted, the cocktail was initiated. So here is nothing that we can use, is use an ultrasound guidance to choose where do we want to put the catheter. Because as you see from the previous slides, he has mets all over the spine, so we don't want to be doing under landmark technique and hitting any of the tumor. So, and of course, you reduce the number of attempts. So if you have seen a cancer patient before who is in a lot of pain, it's not easy to position them in a lateral position or even a sitting position. They can't tolerate it. So you got to do it quick, fast, and furious. Sorry, not furious, just quick and fast. All right, so following in the insertion, the pain at right hip was well controlled, right? And we hope that, at L3, L4, we put at L3, L4, and then we hope that the local will spread all the way up to the thoracic level for the chest pain, right? This is just wishful thinking, of course. It didn't spread away, and he was still having pain. Say, oh, my hip pain is well under control now, and my chest pain is still there. I say, oh, why are you not happy with this? Oh, because I still have chest pain. So again, we need to think of things that, how can we help him? But he's already planned for radiotherapy to right femur lesion and lesion around the left ribs. But what can you do in the meantime? Every night he's groaning in pain, he's moaning in pain, he won't sit up. Every time you see him, he complains to you. And my MO is to go and see, Dr. Khoo, I don't want to see him anymore because he's in pain. I don't know what to do with him. So what are the options we can have? Number one, we can just wait and leave it, right? Wait and leave it. Wait for the radiotherapy to take place. Or we can offer him probably intercostal nerve blocks, multiple level, block T1, T2, T3, T4, all the way down 12 injections. Or maybe thoracic paravertebral block, maybe at one level and see whether it spreads, and see whether it spread 8 segments or 2 segments. Using ultrasound, because with ultrasound, we can see actually where the spreads up. We can inject at one level and we trace up to the next level, see how well the local anesthetic spreads. So what we did was we tried a T4 thoracic paravertebral block. So we scanned at T4 level, and good enough when it was the first 5 mil went in, the spread was good. It all spread at least to T2 and T6, and we kept on injecting a total of 10 mils first. Then we put a catheter in, and the rest of 5 mils, so make sure that the catheter is in place and is not in the epidural space or in an intrareticular space. So the post-procedure, the pain reduced for 8 or 9 to 2 to 3, and it provide good pain relief. And the oncologist actually told me confidently that, with the radiotherapy, within 5 days, the pain will go away. So with this, then we think that, okay, so the paravertebral block is just for temporary, go for the radiotherapy, the pain will go, and after 5 days, when the radiotherapy kick in, we can take off the paravertebral block and he can go home, right? Simple. This is the plan. But, not everything goes on to plan. Of course, he went to radiotherapy. Even with the radiotherapy, the pain didn't go away, the chest pain. So we left the catheter in actually for 3 weeks, and he provided pain relief. I mean, we need to adjust the infusion rate there and then, and he passed away about 3 weeks later. All right. Just thinking out of the box, how can regional? I mean, we've been talking about how regional anesthesia we can use for anesthetic patient for breast surgery, for hips surgery, head analgesia. For this group of patients, can we think out of the box to help them? All right. So let's say this is a real patient, a girl with a tumor of the right hand, and she's supposed to go for radiotherapy, but she can't open her right fist because it's just too painful. Can we just do a catheter technique so that she can open the right hand and she can have the radiotherapy? It's something we should think of. And like I said, let's say she's going to have radiotherapy. Before that, should we just do a block first while waiting for the effect to take place? And maybe providing pain relief as part of our end-of-life care. And of course, if you're thinking of doing a neurolysis procedure before and to see whether it helps with the pain, we need like a diagnostic block first. Like for shoulder pain, we can always try to block the suprascapular nerve. It works. Then we can always use a phenol injection to neuralize the pain, or even do a radiofrequency ablation of the nerve. But invariably, in this sort of chronic pain patients, we will need a catheter. All right, and I think in the next session, Dr. Eng is going to talk more about how we put in catheter, how do we secure it, the technicality of it. So I mean, I've searched through the internet and I found this case report. Actually, they do a tap block with phenol. It's just as one case report, so I'm not sure whether how safe it is injecting phenol into the tap space. But actually, the patient survived and they provide good pain relief. Right. So I may move on to the next thing: how managing acute pain in a chronic pain patient. All right. So I'm sure that, like I said before, there are 30% chronic pain patient moving around in the Western country. So I mean, in Malaysia, I think these numbers is going to go up. So it's going to come to you for surgery, and if you are not careful, then we're going to have trouble managing their pain. So this is a 26-year-old gentleman. He has a crushed injury of the right foot with toe fracture of right femur. So right BKA done. During that time, the pain control was difficult. He has history of alpha discectomy, epidural attempted, but difficult to pass through catheter. So after that, he was discharged, but he developed chronic neuropathic stump pain. So it's under pain clinic control, and we managed to control his pain with gabapentin and CBT. I mean, cognitive behavior therapy. So the right femur is non-union despite the plating, So she was planned for iliac bone graft. So he went for the surgery without telling anyone. And the anesthetist in charge just did a regular GA, normal 100 mic of fentanyl with 6 milligrams of morphine. And post-op, he had severe pain at both the surgical site and the stump site. So the stump, which is having a neuropathic pain, is having more pain than the surgical site pain. And he needed ketamine infusion in addition to the strong opiate that he was having. So if you see the stump here, he's not contracting his muscle voluntarily. Can you see the fasciculation? So this is just happened spontaneously. So I'm not sure what it is. I mean, I've sent this video to a lot of rehab physicians. They don't know what it is, but she's having a lot of pain from that. Neuropathic pain over this lateral aspect of the stump here. All right? A lot of fasciculation. Maybe it's due to sensor sensitization, because after the surgery, the pain pathway just go haywire. So we push him to the OT, maybe you can see whether there's any neuroma there. There was no neuroma, there's just nerve branching. You can see the tibial nerve and the common peroneal nerve, both traced and ended posterior to the knee joint. So we injected around the nerve, and after, it was actually a peroneal nerve that the pain disappeared and the fascicle stopped. But as usual, it only lasted for 48 hours, but his pain was less, and he agrees to go home after that. So I thought that our problem was over because he went for surgery and he just go to pain clinic and everything is done. He managed to have the medication. But then, again, the orthopedic team is, they like to do stuff. So they plan for, they become more ambitious. So they want to remove the plate now because the femur is not thinking. They want to do a retrograde nail over the right femur. And they want to remodel the BK stump. They want to cut off some of the bone of the stump and reconstruct the flap again. Can you imagine the pain she's going to have? And difficult to put an epidural. How are we going to manage this kind of patient? How are we going to manage the pain? So we should consider whether he's opiate tolerant, because he's been on tramadol for a long time. How do you assess his pain? He's going to tell you his pain score is 4 or 5 all the time. It's not going to be 0, but it's a 4 or 5. Yeah, I'm okay, 4 or 5. And is there any pre-existing central sensation we're going to look at? So how do we reduce this? How are we going to reduce this, going for the surgery? Okay, let's say there's a patient coming to you now. All right, I know most of us think that, never mind, just give another GA post-op, the pain team, the APS team will handle it. It's not my problem anymore. Bye-bye, I go home and off my phone, right? So we got to use, the focus mentioned is to use effective analgesia, all right? Effective means not too much, not too little, just right. Use of strategies that will attenuate tolerance or opioid-induced hyperalgesia. We cannot give too much opioid. Give too much opioid, he'll get opioid-induced hyperalgesia. If he's on long-term opioid, you've got to prevent his withdrawal. But we must always have close liaison with all the team, because it's always a multidisciplinary treatment of patients with chronic pain. So you've got to look at the pharmacological, non-pharmacological treatment. And in the center here, there's always a multimodal analgesia. When we go for exam, it's always how do you treat this pain? It's multimodal analgesia. So regional anesthesia here is like fitting into the puzzle nicely, all right? So how will you anesthetize? He can't have an epidural because he can have a single shot spinal, but epidural we tried before, it couldn't go in, just couldn't go in, because he has a previous discectomy. So what we did was, perioperatively we see him in the NS clinic. We started his gabapentin. He offered himself because he think that he could manage. But we explained to him, we discussed with him about his expectation, what he expect, what medication we give him, what block we give him, and what to expect out of the surgery. So of course it has to be done under GA. So pre-nationally we did a fascia iliac block, although I know that Dr. Victor Chi doesn't believe in fascia iliac block, but this is a retrograde link. I think it helps, I think. Okay, and also a sciatic nerve block, which is I think is the most important here, given that previously he had a sciatic nerve block and it works for his fasciculation, and now they're going to cut his tibia again, and they're going to do a flap. But we know that he will need a catheter because he will be in pain for the next 3 or 4 days. But of course, the surgeon said, "Oh, your catheter is in my surgical field. Please remove it," all that kind of thing. So okay, fine, all right. So we plan to put the catheter after the surgery, but we did give her a single injection first. So with this, and of course we give him some ketamine infusion, fentanyl bolus, because ketamine is to reduce the opioid tolerance, kind of thing. and morphine only during wound closure. So post-operative, he was fine. The catheter running at 5 meters per hour. On top of that, ketamine infusion, and he has a PCA movement. So he has everything in the world except COX-2. Why? Because he has asthma, and before that he has a bronchospasm before, so he can't have a COX-2. So the patient pain was well controlled, and above was weaned off one by one and was discharged by gabapentin and tramadol. So this is just one of the instances where the patient comes to you. Got to screen them whether they have chronic pain. If they have chronic pain, you got to be really careful, and you got to offer them multimodal analgesia. And I think regional analgesia is one of the things that we should offer to them on top of the whole armamentarium of ketamine, opioid, and also COX-2. Right. Right. Third, so managing pain for wound dressing. I thought it's just 20 minutes, right? I've started. So I'm going very quick, just 5 minutes. So this is a 13-year-old boy with pull wound healing because there's a wound there. I tried to search for any evidence in the literature, but I couldn't find anybody that uses a catheter for wound dressing. So difficult wound care because, it's the 13-year-old boy. They tried to dress him, couldn't dress him. So we did a cytic nerve catheter with patient control with a baseline, and he's more cooperative, we're able to do dressing, and after that he could walk in the ward. This is a mobile PCR machine, CAT Legacy. Okay. Even for chronic leg ulcer, this lady has a chronic leg ulcer because of the antiphospholipid syndrome, and she was comfortable after that. So regional anesthesia for wound dressing. All right, sorry. So the idea is you provide good pain relief, you can do effective dressing, you can get good wound healing, or you block the sympathetic blockade, you get the vasodilatation, better blood flow, you get wound healing, right? That's the idea. Okay. So next, this is my last thing I'm talking about. How can regional analgesia prevent chronic pain? So as you see there, the incidence of chronic pain is really high, especially amputation is about up to 85%. So these are the various risk factors, but the most important is one of them is inadequate analgesia techniques. So we need to provide good analgesia technique in order to prevent chronic pain post-surgery. So the good evidence here from this meta-analysis here is let me go here. This is a level of evidence, sorry. Thoracic epidural analgesia for thoracotomy and perioperative block for breast. This is all level 1 evidence. Okay, this is good. All right. Level 3 evidence is just spinal for Caesar and cesarean delivery. And for severe phantom pain is perioperative epidural analgesia, but it's only level 3 evidence. So no strong evidence yet for peripheral and truncal blocks, but I think it's something that we can go look into. We can do studies and see whether there's any sort of evidence for preventing chronic pain. So in summary, okay, I'm finishing. So this is what I've talked about today. So for cancer pain is a step 4 of the WHO ladder. All right. So managing acute pain in a chronic pain patient, remember, has to be multidisciplinary and has to be a multimodal, which is the regional anesthesia fits nicely into here. And for wound dressing, of course, if you can provide good pain relief, effective dressing, vasodilatation, better blood flow with healing. And to prevent chronic pain, the good level 1 evidence so far is for thoracic epidural and analgesia for thoracotomy and perioperative block for breast surgery. So with that, I've ended my presentation. Thank you.
Thank you so much, Dr. Khoo Eng Lea. Any questions from the floor while waiting for Dr. Pankaj Kudra?